Welcome to the deep dive. You're probably here because you want to really get to grips with pernicious anemia for revision, right?
Yeah, it's a key topic.
So think of this as your focused revision session. We'll take all the essential information, break it down, make it conversational.
Exactly. The mission, if you like, is to give you those high-yield facts, maybe some mnemonics, memory tips, just to help it all stick.
Okay, let's dive in then. Pernicious anemia, what exactly is it at its core?
Okay, so fundamentally, pernicious anemia is an autoimmune disorder. It specifically targets the stomach lining, the gastric mucosa.
Right, where digestion really kicks off.
Precisely. And this autoimmune attack messes things up so the body can't absorb vitamin B12 properly, leading to a deficiency.
And the key problem is something called intrinsic factor.
That's the one. The body stops producing enough, or any intrinsic factor, or IF. It's a protein made in the stomach, and it's absolutely essential, kind of like a chaperone, for getting B12 absorbed later on.
And the name pernicious, it sounds quite serious. Does it hint at how it develops?
It does, yeah. Pernicious basically means harmful in a gradual, subtle way. The symptoms often creep up slowly. They're not always dramatic, which means, diagnosis can sometimes take a while.
Right, it's not like a sudden illness. Okay, so let's just quickly recap B12 absorption normally, because that really explains why losing intrinsic factor is such a big deal.
Good idea. So we get B12 mostly from animal products, meat, dairy, eggs.
Okay.
But it's not absorbed in the stomach. It travels down to the very end of the small intestine, the terminal ileum. That's the specific spot for absorption.
And intrinsic factor made back up in the stomach by parietal cells has to travel with it.
Exactly. It binds to the B12, protects it, and then facilitates its uptake in the ileum. Think of it like needing a specific key, the IF, to unlock the door into the bloodstream for B12.
No IF, no key, no B12 absorption.
Got it. And do we store a lot of B12?
Actually, no, not a huge amount. The body typically holds maybe 2 to 3 milligrams. That might sound tiny, but it can last quite a while, maybe 2 to 4 years.
So that again fits with the gradual onset, the pernicious nature. Exactly. The stores deplete slowly.
So what's actually happening in the stomach during this autoimmune attack? It's more than just IF production stopping, isn't it?
Oh yes, it's an active attack. The body's immune system mistakenly targets cells in the stomach lining, particularly in the upper parts, the body, and the fundus.
Right.
This causes inflammation, gastritis, and over time, atrophy function. The lining thins out, wastes away. You lose the normal structure, the gastric glands, and critically, you lose the parietal cells and chief cells.
And parietal cells make acid and intrinsic factor.
Correct. So the autoimmune destruction leads to both echlorhydria, a lack of stomach acid, and the absence of intrinsic factor. It's a kind of double whammy from the attack.
Okay. So autoimmune attack leading to no IF is the definition of pernicious anemia. But are there other ways someone could end up B12 deficient, not necessarily PA?
Absolutely. That's a really important point for differentials. While PA is specifically autoimmune IS deficiency, other stomach problems can cause B12 deficiency too.
Like surgery.
Exactly. If you've had your stomach partially or fully removed, a gastrectomy or resection, you'll naturally make less IF. Chronic atrophic gastritis from other causes, not autoimmune, can do the same.
What about infections like H. pylori?
Yeah, H. pylori can sometimes contribute, potentially leading to atrophy over the long term. And then there are very rare genetic conditions where someone's born without the ability to make IF properly.
And diet. We always hear about vegans and B12.
Right, and that's crucial. A strict vegan diet, if it's not supplemented or using fortified foods, can definitely lead to B12 deficiency because B12 is mainly in animal products. But that's dietary deficiency, not pernicious anemia. Different cause.
Okay, distinction made. And it's not just the stomach or diet. Problems further down in the intestine can matter too.
Yes, definitely. Because absorption happens in the terminal ileum, anything affecting that specific area can block B12 uptake.
Like what sort of conditions?
Things like Crohn's disease, if it involves the ileum, surgical removal of the ileum, obviously, general malabsorption syndromes, chronic tropical sprue, even HIV or radiotherapy to that area can damage the ileum and impair absorption.
Okay. And you mentioned medications earlier too. I wouldn't necessarily jump to that.
Yeah, it's worth remembering. Some drugs like colchicine, neomycin, metformin, which is really common, and certain anticonvulsants have been linked to lower B12 levels.
And what about things like PPIs, the acid blockers?
Good point. Long-term use of proton pump inhibitors or H2 blockers can worsen B12 deficiency. Stomach acid actually helps release B12 from the food protein in the first place, so reducing acid can hinder that initial step.
Right, makes sense. Okay, so that covers the what and why. Who actually gets pernicious anemia? Are there specific risk factors?
Yeah, there are. Demographically, it tends to be more common in women. The ratio is about 1.6 women to 1 man. And it typically shows up in middle to older age.
Any strong associations?
A big one is other autoimmune diseases. If someone has PA, they're more likely to also have conditions like autoimmune thyroid disease, type 1 diabetes, Addison's disease, rheumatoid arthritis, or vitiligo.
That makes sense. The immune system being generally predisposed. Is there an easy way to remember those associated conditions?
There is. You can use the mnemonic RAVE. T for thyroid, A for Addison's, D for diabetes type 1, RA for rheumatoid arthritis, and V for vitiligo. RAVE.
TAD-RAVE. Nice, okay. Anything else?
One other interesting link is blood group. It seems to be a bit more common in people with blood group A.
A for autoimmune, A for blood group A. That's a handy little hook.
Exactly, helps it stick. Okay, so should we dig a bit deeper into the pathophysiology, like what the antibodies are actually doing?
Yes, let's do that. We know it's an autoimmune attack, but what are the specific targets?
Okay, so there are primarily two types of antibodies involved. One type targets intrinsic factor itself. These antibodies can physically block the site on the IF molecule where vitamin B12 is supposed to bind. So even if IF is produced, it can't grab onto the B12.
Okay, so it neutralizes the IF and the other antibody?
The other type targets the gastric parietal cells, the cells that actually produce both IF and stomach acid.
Ah, so that's the one causing the atrophy we talked about.
Precisely. These antibodies lead to inflammation and destruction of the parietal cells, which directly reduces the amount of IF being produced in the first place, and also reduces acid production.
So you've got antibodies stopping IF from working and antibodies stopping IF from even being made.
Exactly. It's a multi-pronged attack that effectively shuts down B12 absorption via this pathway.
And remind us again why lacking B12 causes the specific problems it does, the anemia, the nerve issues.
Yeah, B12 is absolutely vital for a couple of key processes.
Yeah.
One is the proper maturation of red blood cells in the bone marrow. Without enough B12, the red blood cell precursors don't divide and mature correctly. They end up large and immature megaloblasts, leading to megaloblastic anemia. These large cells don't carry oxygen efficiently.
Hence the fatigue, breathlessness.
Exactly. The other crucial role for B12 is in synthesizing and maintaining myelin, the protective fatty sheath around nerve fibers.
Ah, the insulation for the nerves.
Right. So B12 deficiency leads to defective myelin formation or damage to existing myelin. This causes the neurological symptoms, the neuropathy, the spinal cord issues. It's why PA isn't just a blood disorder, it's a neurological one too.
That really underlines why getting the diagnosis right is so important. Which brings us to differential diagnosis. If someone has, say, macrocytic anemia, how do we distinguish PA from other causes?
Great question. The main differential for the megaloblastic type of macrocytic anemia is folate deficiency. Folate is another B vitamin, also crucial for red cell production.
Okay, and what causes folate deficiency? Is it mainly diet?
Diet is a big one, yeah.
Yeah.
Lack of green leafy veg. Also, certain situations like relying heavily on goat's milk, which is low in folate, but also malabsorption. Things like celiac disease, gluten-induced enteropathy, tropical sprue,
What else?
increased need, think pregnancy, or periods of rapid growth like prematurity. Chronic hemolytic anemias like sickle cell disease use up folate faster. Some malignancies too, increased loss, maybe through the kidneys in some conditions. And like B12, certain drugs can interfere anticonvulsants again, sulfasalazine.
Wow, quite a list. Is there a quick way to group those?
You could try thinking F factors: food, diet, fetus pregnancy growth, failure, renal loss, folate antagonists, drugs. Might help jog the memory.
F factors. Got it. Now, you mentioned folate deficiency also causes megaloblastic anemia. Does it cause the nerve problems like B12 deficiency?
This is the critical point. Folate deficiency can sometimes cause neurological problems, including subacute combined degeneration of the cord, even if the serum B12 level looks normal. Yes. And there's also the issue of functional B12 deficiency, where serum levels are okay, but there's a problem with transport inside cells, maybe due to issues with transcobalamin too.
Yeah.
So the absolute rule is, if you have megaloblastic anemia, you must check both B12 and folate levels before treating, especially before giving folate.
Because giving folate could mask the B12 deficiency anemia while the nerve damage gets worse.
Exactly that. It's a major potential pitfall.
Okay, so that's megaloblastic anemia. But sometimes you just see macrocytosis, big red cells, without those specific bone marrow changes. What else causes that?
Right. Simple macrocytosis, several things. Pregnancy, sometimes newborns. Alcohol excess is a very common cause. Liver disease, too.
Okay.
Severe hypothyroidism can do it. Also, think about reticulocytosis when the body is churning out lots of new young red cells, which are naturally larger after blood loss or hemolysis. That can raise the average cell size, the MCV.
And even blood disorders themselves.
Yes, definitely. Things like red cell aplasia, plastic anemia, myeloid leukemia, myelodysplastic syndromes, they often feature macrocytosis. Even non-blood things like changes in plasma proteins, like in myeloma, can sometimes affect the MCV reading. And again, drugs ones affecting DNA synthesis like azathioprine or hydroxyurea.
So a high MCV needs careful thought. Right, let's talk numbers. Epidemiology. How common is pernicious anemia in the UK?
Estimates vary a bit, but the prevalence is thought to be somewhere between 0.1% maybe up to 1% of the population.
And new cases each year?
The incidence is lower, maybe 1 to 5 new cases per 100,000 people per year. But remember, general vitamin B12 deficiency is much more common.
Right. You mentioned the figures earlier, especially in older people.
Yeah, maybe 6% of under 60s, but jumping to around 20% in those 60 and over in the UK might have low B12, and around 11% of vegans if they're not careful with intake.
So PA is the most common cause of B12 deficiency leading to megaloblastic anemia, but not the only cause of low B12 overall. Any key demographics for PA itself?
We mentioned more common in women. Northern European descent seems to have a higher prevalence. Peak age is typically 40 to 70 years. Average onset may be 60 in white individuals.
And you mentioned something about different patterns in Black individuals.
Yes, the mean onset age tends to be a bit younger, around 50. And interestingly, particularly in young Black females, there seems to be a bimodal distribution, meaning peaks in both younger and older age groups. The reasons for that aren't fully clear. Likely a mix of genetic and environmental factors still being researched.
Interesting. Okay, let's picture a patient walking in. What clinical features, what symptoms and signs should make us think, could this be pernicious anemia?
Well, you've got the general symptoms of anemia first. Fatigue, feeling wiped out, lethargy, looking pale, maybe getting short of breath on exertion.
Standard anemia stuff. What about the neurological side?
That's really key. Peripheral neuropathy is common. Often symmetrical pins and needles. Yeah.
Numbness,
Usually worse in the legs. Then you can get the more serious subacute combined degeneration of the spinal cord. That presents with things like muscle weakness, difficulty walking, clumsiness that's ataxia, odd sensations, paresthesias, and sometimes spasticity or stiffness.
And cognitive or mood changes?
Yes, neuropsychiatric symptoms are definitely part of it. Memory problems, poor concentration, confusion, sometimes irritability or even depression.
Any other characteristic signs?
Sometimes patients develop mild jaundice along with a pallor from anemia, giving the skin a sort of yellowish or lemon tinge. Glossitis, a sore, red, smooth tongue, is also quite classic. In general, things like palpitations or headaches can occur too.
And on examination, what might we find?
Well, signs of severe anemia, potentially even heart failure in advanced cases. That lemon-tinted skin is a visual clue. You might see mouth ulcers. Neurologically, you'd test sensation, reflexes which might be reduced, or absent check for spasticity, and assess coordination for ataxia.
And the more severe psychiatric signs?
In some cases, you might see paranoia, delirium, or significant depression. If the anemia is really profound, you might find an enlarged liver or spleen hepatosplenomegaly, and as mentioned, signs of heart failure, often tipped over the edge by something like an infection.
Okay, quite a spectrum of possibilities, so we suspect it. What are the first-line investigations?
Blood tests are paramount. Start with a full blood count, looking for that macrocytic anemia high MCV. And on the blood film, look closely for hypersegmented neutrophils, those polys with too many lobes.
The megamacrocytes, hyperpolys as a reminder.
Exactly. Then, absolutely crucial, check the serum vitamin B12 and folate levels.
What sort of B12 level is generally considered normal?
Usually a level above 200 nanograms per liter is seen as normal, but you have to interpret it in context. Sometimes levels in the lower end of normal or even normal levels can still be associated with deficiency symptoms, especially neurological ones.
Right, clinical picture matters. And the antibodies.
Yes, the autoantibodies are key for diagnosing pernicious anemia specifically. We test for anti-intrinsic factor antibodies, IFAB, and anti-gastric parietal cell antibodies, GPCA.
How useful are they?
IFAB is the important one. It's highly specific if it's positive. It's almost certainly pernicious anemia, but it's not very sensitive, only positive in about 50%, maybe 40–60% of cases.
So a positive IFAB confirms PA, but a negative doesn't rule it out.
Correct. The GPCA is positive much more often, maybe 80% of PA cases, but it's less specific. You can find it in about 10% of healthy people and in other autoimmune conditions too.
Okay, so IFAB is the clincher if positive. What about that old Schilling test? Does anyone still do that?
Not really, no. The Schilling test, using radioactive B12 to track absorption, is pretty much obsolete now. It's been replaced by the antibody tests and assessing the clinical response to B12 treatment. It's mainly historical interest.
Got it. Any other tests sometimes needed?
Occasionally, if the diagnosis is really unclear, a bone marrow aspirate might be done to confirm megaloblastic changes. Testing gastric secretions for acid and I isn't common practice anymore.
What about endoscopy, looking inside the stomach?
Gastroscopy might be considered, but mainly if the patient also develops iron deficiency. The chronic atrophic gastritis in PA carries a small, slightly increased long-term risk of gastric cancer, so unexplained iron deficiency would warrant a look. But routine screening endoscopies for everyone with PA isn't standard. The risk increase is relatively small, not usually a major cause for patient alarm, but something clinicians are aware of.
Okay, makes sense. So we've diagnosed pernicious anemia. How do we manage it?
Management is centered on replacing the missing vitamin B12. Because the problem is absorption, the standard initial route is intramuscular injection.
Right. What's the usual starting dose?
Typically, we use hydroxycobalamin. If there are no neurological symptoms, a common starting regimen is 1 milligram intramuscularly 3 times a week for 2 weeks.
And then long-term?
After the loading doses, it usually drops to a maintenance dose of 1 milligram every 3 months, lifelong.
What if the patient does have neurological symptoms?
Then the treatment needs to be much more intensive, especially initially. It's often 1 milligram every other day until the neurological symptoms stop improving.
And maintenance after that?
Maintenance might then be 1 milligram every 2 months, again, usually lifelong. The goal is to saturate the body's stores and provide enough B12 to bypass the absorption issue and hopefully reverse or halt nerve damage.
Can oral B12 ever be used?
High-dose oral B12 can sometimes be used for maintenance in some patients, but it's generally not the first choice for initial treatment, particularly if there's neurological involvement or severe deficiency. IM is more reliable for bypassing the absorption block.
And what about folic acid? Do we add that routinely?
Sometimes folate levels are also low and need replacing. But, and this is the crucial bit we keep mentioning, always check the B12 level before giving folate if you see macrocytic anemia.
Don't mask the B12 deficiency. Don't worsen the neuro problems.
Exactly. If B12 is low, treat that first or at the same time. Never give folate alone if B12 deficiency is possible or confirmed.
So for neurological presentations, prompt and aggressive B12 treatment is key.
Absolutely critical. The sooner adequate B12 treatment is started, the better the chance of neurological recovery. Delay can lead to permanent disability.
Okay, so just to summarize those doses for revision. No neurosymptoms, 1 milligram IM 3 times a week for 2 weeks, then 1 milligram every 3 months. With neurosymptoms, 1 milligram IM alternate days until stable, then 1 milligram every 2 months.
That's a good summary. And sometimes prophylaxis is needed, maybe 1 milligram every 2–3 months, if someone has a known reason for malabsorption but not PA itself.
When would we need to refer someone on to a specialist?
Okay, referral guidelines. Urgent referral to hematology is usually needed if there are neurological symptoms or if the patient is pregnant.
Right.
Consider routine hematology referral if the cause of the anemia isn't clear, if you suspect an underlying cancer or another blood disorder.
And gastroenterology.
Refer to gastro if you suspect malabsorption is the primary cause, if there are significant GI symptoms, or, as we mentioned, if there's concern about gastric cancer.
And dietitians.
If the deficiency seems likely to be diet-related rather than PA, then a dietitian referral is really helpful for advice on intake.
What about those borderline cases? Low B12 on a blood test, but no anemia, no clear symptoms, subclinical deficiency.
Yeah, that's a common scenario. It needs clinical judgment. You might repeat the B12 level in a month or 2. If you strongly suspect deficiency based on vague symptoms, you might give a trial of B12 therapy and monitor carefully, especially for any neuropathy.
And the antibody tests come back?
If the anti-IF antibody is positive, even without symptoms, that usually implies PA and warrants lifelong B12 treatment. If ISAB is negative but B12 is low, you might need more tests to find the cause. Sometimes other tests like holotranscobalamin active B12 or methylmalonic acid, MMA, can help clarify, but essentially, positive IFAB means lifelong treatment.
Okay, so the main message for PA is lifelong B12 replacement and monitoring.
That's the key takeaway for management.
And if people stick to the treatment, what's the prognosis?
Generally, it's very good. With regular B12 injections, people usually respond quickly, feel much better, and can expect a normal lifespan with minimal morbidity from the PA itself.
That's great news, a stark contrast to before treatment was available.
Absolutely. Before B12 replacement, it was, as the name suggests, pernicious, gradually progressive, and ultimately fatal due to the severe anemia or neurological damage.
So while the prognosis is good now, complications can still happen if it's missed or treatment isn't consistent.
Yes. The main risks are the long-term consequences of severe anemia, like strain on the heart and irreversible neurological damage.
Can you list the main potential complications again?
Sure. Hematologically, severe anemia leading to cardiopulmonary problems. Neurologically, persistent pins and needles, paresthesia, poor balance and coordination, ataxia, peripheral neuropathy, sometimes visual problems, psychiatric issues like depression or memory loss, and the big one, subacute combined degeneration of the cord.
Anything else?
We mentioned the risk in pregnancy, increased chance of neural tube defects like spina bifida in the baby if the mother is B12 deficient. It affects bone marrow function generally, and some sources suggest severe deficiency might even cause temporary infertility.
And the gastric cancer risk.
Yes, there's that slightly increased long-term risk associated with the chronic atrophic gastritis that underlies pernicious anemia. Important to be aware of, but again, the absolute risk increase is small for any individual patient.
Okay, so let's quickly wrap up the key points for revision. Pernicious anemia, it's autoimmune, targets the stomach, stops intrinsic factor production, leads to B12 deficiency.
Which causes macrocytic anemia and potentially serious neurological problems. Diagnosis relies on blood tests, B12 levels, and especially intrinsic factor antibodies.
And the management cornerstone is lifelong B12 replacement, usually injections, crucially remembering never to give folate alone if B12 might be low.
Exactly. Understanding that whole pathway from the stomach autoimmunity to the blood and nerve effects is key.
It really is a fascinating link, isn't it? How a localized immune issue in the stomach has such far-reaching consequences. It makes you wonder, maybe, what other conditions that seem quite separate might share these kinds of hidden underlying connections. Something to think about.
Definitely food for thought.
Well, if you want to solidify your understanding of topics like this and sharpen up for your exams, do check out passmsra.com and freemsra.com. Loads of great resources there.
They really are helpful.
Thanks for joining us for this deep dive on pernicious anemia.